This episode is brought to you by the Fempower Health Perimenopause and Menopause channel. If you're not subscribed and want to learn more about perimenopause and menopause, make sure to subscribe wherever you listen to podcasts. You can search for Fempower Health Perimenopause Menopause channel or click the link in the show notes. And if you're interested in chronic pelvic pain, we also have a dedicated channel for that. Search for Fempower Health Chronic Pelvic Pain channel to explore more.
We have a crew of aging women who are going through perimenopause and menopause and who are not their mothers. They do not want to take, I don't know, I don't care for an answer. They will demand better of you.
Welcome to Fempower Health. This is Georgie. In today's episode, we're diving deep into one of the most important and often misunderstood topics in women's health: hormone therapy and cancer risk. I am thrilled to welcome Dr. Michelle Jacobson, a leading expert in menopause and menopause oncology, to break down the complexities around hormone therapy, its benefits, and the risks associated with cancer. I heard Dr. Jacobson speak at the recent ACOG conference, which is also American College of Obstetricians and Gynecologists, and it was held in San Francisco in May 2024. And as soon as I heard her speak and her data-driven approach to have shared decision-making with her patients, I knew she had to be on this podcast, and I so appreciate that she said yes. So Dr. Jacobson shares invaluable insights on how to navigate these decisions through shared decision-making, highlighting the importance of personalized care. As you can see, this episode is packed with so much helpful and important information that I know you want to be aware of. So take a listen. Dr. Jacobson, thank you so much for joining me on the Fempower Health podcast. I fondly remember meeting you at ACOG. I was sitting in the room, and I think the discussion was on vasomotor symptoms. The layman's term is hot flashes. And I listened to you and your colleagues speaking, and I will say what you shared absolutely blew me away. It was incredibly data-driven conversation and all about how to properly do shared decision making when it comes to hormone therapy for menopause and cancer risk. And this is one of those topics that is highly discussed. It's a top search term for hormone therapy. I have discussed it on the podcast before, but just given the way you talked about it, I think I ran up to you. I was like, can you please come on my podcast? And we finally made it happen. So here we are. So before we dive in, tell us a bit about your background. And I took a bunch of notes from ACOG. And so I'd love to use those as a guide because I want others to hear the incredible things you shared there. But obviously, you'll share some stuff here as well. So tell us about you, and then we'll dive in.
Thank you. So, thanks for having me on the podcast. It only took us a couple months to get this organized. We met in May in San Francisco. I am an OBGYN by training, and I have a specialty and subspecialty in menopause, and then particularly in menopause oncology. So, women who are menopausal because of cancer treatment, or women who have difficulty managing menopause symptoms because of the implications of their cancer diagnosis. So I have a generalist practice here in Toronto, Ontario, where I'm primarily a gynecologist seeing women with menopause complaints, as well as I direct a familial ovarian cancer clinic. So this is a clinic for women at high risk for breast and ovarian cancer because of genetic mutations.
I almost want to start with the punchline, which is, what does the data say? Should we be concerned with hormone therapy and cancer risk? I recently interviewed a clinician who said, based on, the data that we have, the risk isn't that bad. It's really all about shared decision making and how comfortable people feel. And that's like the punchline. I was like, wait, what? And so this is why I'm excited I had that interview first, and now I'm talking to you because from what you shared, it's complicated. So can you just address like that punchline piece, and then we can dive into these different use cases and other nuances you shared at ACOG?
Totally. And I agree with you. The important part here is shared decision making and individualized recommendations. So there is no one size fits all approach to managing menopause. Every person needs to have their specific story, the things they're worried about, the things in their medical background, what they can afford to take taken into account when it comes to finalizing what that prescription or recommendation is going to be. Cancer risk is a very nuanced question, and there are lots of different ways you can approach that. Your question was, do we need to be worried about cancer risk when it comes to hormone therapy? And the long and the short of it is probably not based on the data that we have. But so much of my practice involves women who already have a cancer diagnosis. And so, what we worry about, especially with the cancers that can be sensitive to hormones like estrogen and progestogens, is are we increasing cancer recurrence risk versus in someone who's completely healthy and might just have a little bit of something in their family history or a concern? That's a very different discussion.
Should we start with like some use cases then? Because when I asked you about the types of cancers, so just so that everyone knows, because I think it is helpful to know the specific types of cancers that you also deal with, is hereditary breast and ovarian cancer like BRCA, menopause after breast cancer, colon cancer, gynecologic cancer, which I'm assuming is like endometrial cancer and possibly others, and stem cell transplants.
Yeah, but stem cell transplants are going to be bone marrow cancers, lymphomas, leukemias, as well as certain other medical conditions where a stem cell transplant's used. And gynae cancer, as you alluded to, could be uterine cancer, but it could also be fibroid cancer, ovarian cancer, of which there are several subtypes, cervical cancer, of which there are several subtypes as well.
Okay. First of all, does it depend on the type of cancer and how you have that conversation? So I guess let's start there.
Absolutely. So it totally depends on what type of cancer you had. Some of them impact decision making around hormone therapy, others don't. But certain types of
Okay.
cancer can actually be considered a contraindication to hormone therapy. So something you would want to avoid if you had had that type of cancer before. And then to complicate matters even further, even those patients could decide that they're willing to take on a risk of cancer recurrence if it's important to them. And that is really part of the individualization process is you are a consenting adult. You are able to understand risk and benefit, and only you can make decisions with the information we can provide to you on what your risk tolerance is when it comes to treatment.
Tell me why these women are saying, "Hey, I need to visit you," so that people kind of understand that journey.
So, menopause management is more than just hot flashes, but for a lot of women, what we call vasomotor symptoms, which are hot flashes and night sweats, are some of the more bothersome symptoms. Women can be put into menopause because of cancer treatment, where chemotherapy can stop them from cycling, in which case, many women will start to cycle again afterwards, depending on how old they were and what their ovarian reserve was like when they had the chemo in the first place. Some women have surgical menopause, where the ovaries are removed. Some women have radiation induced menopause, where the ovaries were in the field of radiation, or they had total body radiation because of a bone marrow transplant. And radiation is really hard on the ovaries. It is almost a foolproof way of putting someone into menopause while they retain their ovaries. And even some other women will be in chemical menopause, where part of their cancer treatment, like for certain breast cancers, includes an injection that puts you into menopause to reduce the total estrogen exposure and reduce the risk of cancer recurrence. So that's common in young women who have breast cancer that's estrogen receptor positive. So when we see these women, regardless of how they've been put into menopause, my first question is always, is there a reason to treat here? And a reason to treat could be quality of life symptoms, hot flashes, night sweats, libido, mood, energy, sleep, all of these things that we associate with menopause. And then, even for the women who don't have those symptoms, if they're young, and especially if they're younger than 45, we want to be treating because they're in early or premature menopause, and there are long term health implications to that early menopause. So, that could include bone weakening, osteoporosis and fracture risk, cardiac disease and blood vessel disease, early brain aging like cognitive decline. So, even for young women who are asymptomatic, which is rare but happens from their menopause, there's sometimes still a reason to treat with hormone therapy. Then there's some women who shouldn't take hormone therapy because of their cancer diagnosis, in which case we're mostly focused on symptoms and best life.
So when you say shouldn't, who would be in that bucket of shouldn't be taking hormone therapy?
So, on most lists of contraindications to hormone therapy, you'll see estrogen sensitive cancers. And breast cancer tends to be the one that's best researched. It's also one of the ones that comes up the most commonly. And this is a fairly clear body of evidence that tells us that taking hormone therapy after all types of breast cancer, including the ones that are not estrogen sensitive, does have an increased risk of breast cancer recurrence. So, we would usually try and avoid using hormone therapy in women who've had any kind of breast cancer. Some of them will even be on hormone blockers as part of their breast cancer treatment. The rest of the cancers are tend to be a little bit more gray. So we think of uterine cancer, for example, as being very estrogen sensitive. And on most lists of contraindications, endometrial cancer is a contraindication to hormone therapy. But we've actually got pretty good randomized control trials looking at women who took estrogen therapy after treatment for early endometrial cancer, so stage one, grade one endometrial cancer, that tells us that in those cases, where the chances of cure are pretty high just from surgery alone, the risk of giving hormone therapy is really minimal because the risk of recurrence is so minimal in the first place.
Okay. Now, for those with breast cancer, this is one where, if I heard it correctly, the risk is still minimal with the breast cancer. So, what is the data really saying here?
I don't think I'd say the risk is minimal. I'd say it depends on the
Okay.
type of breast cancer and the
Okay.
quality of evidence that we have. So, the
Got
best
it.
evidence that we have for breast cancer recurrence risk is from randomized control trials that were done in Sweden in the early 2000s. So, there were two large studies that happened around the same time. One was called the Habits trial, and the other was called the Stockholm trial. And these were randomized control trials where women who had a history of breast cancer, and it included estrogen receptor positive as well as triple negative, who mostly had been treated with breast sparing surgery. So most of them had had lumpectomies and still retained their breasts. Some of them were given placebo, and others were given hormone therapy in different regimens among the two studies. And the caveat here is that the hormone therapy that was used was estrogen therapy and synthetic progestins. And we know in general that synthetic progestins are less good for the breast than natural progesterone or than a way that you can take hormone therapy without any progesterone at all. But
Right.
nonetheless, while these women were followed, they did see an increased risk of breast cancer recurrence, where the women who were in the placebo group recurred about 7% of the time, and the women that were in the hormone therapy group in one of the studies recurred about 17% of the time. And in the other study, while they followed women for 10 more years, they also saw more recurrences in the women who had taken hormonal therapy. So the conclusion from that is that hormone therapy increases the risk of breast cancer recurrence compared to if you don't take it by about 10%. But all of those recurrences, for the most part, were in the breast, either the same breast or the other breast, with very few distant mets and very, very little implication on mortality. So, again, this becomes a very personalized decision about going through treatment again, acceptance of a recurrence full stop, and the type of treatment women had, where most of these women still had their breasts. So many women we see, especially with hereditary mutations, actually do breast removal surgery because the risk of a
Right.
second breast cancer is so high.
Right. And so, if you've had the mastectomy, does that mean it's probably even less risky to take hormone therapy?
Probably even less risky is probably the best way you could describe it because there really isn't good data out there looking at those specific women. Because again, women who've had breast cancer don't take hormone therapy, even if they've had a mastectomy.
What about the progesterone versus the progestin? Because that study, did they look at they didn't have a progesterone arm, did they?
No. So in these randomized control trials of women who had had breast cancer, they used synthetic progestins in the two different studies. Different synthetic progestins, but synthetic ones nonetheless. One of them used it continuously, and the other one used it in a more cyclic fashion. But at the end of the day, at the end of the 10-year follow up, both showed an increased risk of recurrence. Now, we
Okay.
don't have the same study done in women who take natural micronized progesterone with estrogen, which is primarily the type of progestin that's used these days when we give hormone therapy. But we do know that in a large study of women who didn't have breast cancer, but who took combination hormone therapy, the ones who took estrogen with micronized progesterone didn't seem to have an increased breast cancer risk in the first 5 years, whereas women who had taken synthetic progestins and the same estrogen did have an increased risk of developing breast cancer the first time. So we're not comparing apples to apples here. It's women who've had breast cancer and women who haven't. But we know that when it comes to developing breast cancer, combination therapy with micronized progesterone is better than combination therapy with a synthetic progestin.
Right. And you know what's funny is when that study came out, everyone was on social media talking about it. And I'm like, no one is talking about that progestin versus progesterone arm. It was driving me crazy because I feel like everyone is talking about estrogen, but not enough people are talking about progesterone. So thank you very much for explaining
I
that
agree.
data.
I think the progesterone piece is really important.
Yeah. So let me ask you this then, because right now, what doctors are saying is if you don't have a uterus, you don't need to take the progesterone. So how does that play a role if we're looking at these studies? Did like one, did they look at whether or not these women had a uterus? So is the progesterone helpful regardless?
Those studies that were at looking at women who'd had breast cancer who took combination hormone therapy did not have an estrogen alone arm. The best estrogen alone arm information we have comes from the Women's Health Initiative study. And that's where women who took conjugated estrogen, which is not the same as estradiol, they are different compounds. When they took it because they had a hysterectomy and there was no progestin included, they did not see an increased risk of breast cancer. And in fact, in the 20-year follow up WHI data, they actually saw that the women who had taken conjugated estrogen alone and were followed for 20 years had less breast cancer than women who were in the placebo group and had taken nothing at all. So, conjugated estrogen is a very different molecule than natural estradiol. We can't extrapolate the same results, but there seems to be something in conjugated estrogen that is favorable for the breast when it's taken on its own.
And are we using conjugated estrogen anymore?
So that depends on your practitioner. Are we using it? Yes. Do we have it available? Yes. Is it readily covered by many drug plans? Yes. Is it in favor? No. So I would say
Oh.
most menopause specialists, and certainly most general practitioners, gynecologists, women's health specialists, tend to think of conjugated estrogen negatively because of the way it's sourced from the pregnant horse urine, because of the fact that it's not bioidentical or body identical. But I'm someone who tends to keep an open mind, and I think we have a lot of good safety data. When it comes to choosing the right treatment for the patient, this is a decision we make together, and we can't ignore the data we have on conjugated estrogen alone and breast safety.
Since you said the words, I have to ask. Body identical and bioidentical, there are people who are saying, "It doesn't matter. It's just a buzzword, blah, 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 blah." Can you please talk to me about this?
Yeah. So bioidentical is a great word that should mean similar to what your own ovary or your own body produces, and theoretically should be very well tolerated, safe, kind of depends on the situation, but that's what bioidentical should mean. Like all things that have sort of been taken into the media and society and marketed, bioidentical has taken on a different meaning. Where now, when people talk about bioidentical, they're usually talking about compounded therapies. The idea behind the movement is it's supposed to be very individualized and perhaps made to be specific for what you're lacking. There's very little evidence out there that suggests that that is helpful or true. At the end of the day, most estrogens get turned into estradiol, which is the most potent form of estrogen that we have. And the concerns with bioidentical hormone therapies that are compounded is that there's very little consistency from a quality perspective. So the concentrations of the hormones are different from batch to batch. You don't have the same quality control mechanisms that go into what's being made in a pharmaceutical company's headquarters versus what's being mixed in a specific drugstore. And I think there's also somewhat of a conflict of interest if I'm the person selling you and prescribing the product, and I also stand to make money off of what you have been prescribed, right? That's a little bit of a conflict, and that's where there is nuance around the bioidentical hormone therapy movement. And if you practice academic menopause management, where you're influenced by the International Menopause Society and the Menopause Society, which used to be NAMS, then you don't really recommend bioidentical hormone therapy. Body identical is a word that my crew has sort of I adopted to refer to we can give you pharmaceutical grade products that are chemically similar to what your own ovary made. They may be better than the synthetic stuff, they may be worse depending on the circumstances, but you don't have to get your physiologic body identical hormone therapy compounded. You can have it prescribed, covered by your insurance plan, and pick it up at any pharmacy.
What would the role be of testosterone? And I bring this up because in the discussion at ACOG, I won't say you because it was mentioned. I know there are a few of you talking, so I didn't write down who said this, but in the past, it had been used for breast cancer as chemotherapy, if I got that right.
So I probably said that, yeah.
There's not clarity around breast cancer risk, but it's not a contraindication. So I guess what do you do with testosterone and why would someone take it and how does someone navigating these cancer risks?
I wish we knew more about
Okay.
testosterone replacement in women than we know currently. The studies that have been done looking at testosterone replacement have primarily shown safety profile that's pretty good, efficacy that's okay, but the way it was studied was not really optimal to answer the question. So, testosterone's primarily been studied for libido, sexual desire in women suffering from hypoactive sexual desire disorder. And the way that was measured in the studies that have been done looked at the number of satisfying sexual events per month. Now, we know from personal experience, from having friends, from being alive, that the way you measure a woman's desire to have sex probably has very little to do with the number of satisfying sexual events per month. She may not have satisfying sex with her partner. She may get interrupted. She may be working. There may be a million other things that actually get in the way of her ability to have those encounters that has nothing to do with her desire to have those encounters. So it's not great literature. So what do we do? Well, we don't have in Canada or in the US a testosterone product that's approved for use in women. Testosterone is definitely a female hormone in that women make testosterone throughout their lives, partially from their adrenal glands and partially from their ovaries. And so when we use testosterone replacement, we use it in order to treat hypoactive sexual desire disorder. We acknowledge that this is an off label treatment. We monitor levels to make sure we're not getting into the field of levels that could lead to irreversible side effects. And we use it in about one tenth the dose that a man's testosterone replacement, which it is approved for, would be.
Okay. And from a getting it paid for perspective, because I know if I feel like there's been a lot of people that are doing like testosterone pellets, and I heard of the story of someone who accidentally gave 10 times the dose, and the woman, the woman, like basically the husband locked himself in a closet. Let's just say that because
Cool.
you can't take the pellets out.
You can't take the pellets out. You don't know how quickly they're going to be metabolized. You don't know the risks of using them. So I would really strongly advise against using pellets, even though it might make you feel really good. At least when you're applying it transdermally, it's going to have not a big impact on liver and cholesterol and triglycerides. It's going to be absorbed directly into the bloodstream in pretty predictable amounts. And you can change the amount you're taking based on your blood levels. So you can follow it and sort of titrate your dose because we don't have great pharmacokinetic studies with testosterone in women to understand how much changes blood levels by how much. So
Right.
we use a product that's pharmaceutical grade, that is prescribed typically and approved for the use in men, just at a lower dose and monitor levels. We don't compound it.
What about getting it covered? And I don't know if in Canada it's different than in the United States.
Uh, yeah,
What's
I
that
suspect it
whole
is. In Canada, if you have a drug plan and it covers that drug, then you'll be covered. You don't have to necessarily apply for, special approval. In the States, it's a little bit different because your insurance company may balk at covering something that is not FDA approved for that indication.
So, as far as like any other reason that you may be giving testosterone, is it much more for just the sexual health aspects, or are there other benefits of taking the testosterone?
There might be other benefits. Yeah, women definitely, I think, will endorse other benefits when they take it. Some will like it, some will not. Some people will
Okay.
say it helps with their energy, their motivation, their ability to build muscle mass, making them feel more like themselves. But if we're being purists and trying to be sort of very evidence-based and academic, and we look to our 2019 International Menopause Society position statement on testosterone use, their recommendation is to use it for purely hypoactive sexual desire disorder in women who are menopausal and not to prescribe it for other reasons. So, my
Okay.
conversations with my patients tend to be like, okay, I understand why you want to use testosterone, but you have a low libido, right? And once they say yes, then I say, great.
Okay. Got it. And no cancer risk there with testosterone that we know of.
Again, not well studied in
Okay.
women, but you're right. Testosterone did used to be used as part of breast cancer therapy because testosterone induces apoptosis, which means cell destruction in breast cancer tumor cells. So I suspect it is safe, but I couldn't say that with current studies.
You know what would be so cool is like some sort of study that looks at estrogen, progesterone, and testosterone and whatever combination and how that impacts cancer risk.
For sure, and it's such a broad question. It would be so cool. The problem is you need research ethics approval to do any kind of research,
Yeah.
and that's all going to be based on what information we currently have and what products are approved for what reason. So it's really hard to do these kinds of really novel studies that would impact these kinds of questions. Now, one group of medications that we have in Canada, in Europe, and elsewhere that you don't have in the States is a product called Tibolone. And tibolone is a combination therapy that gets metabolized into estrogen, progesterone, and androgen. And there is randomized control evidence of using tibolone after breast cancer, where they saw an increased risk of estrogen receptor positive cancers recur, but not in the 12 months that they followed women for an increase in the estrogen receptor negative cancers. So, again, when it comes to this sort of nuanced discussion, if I have a patient with an ER negative breast cancer who wants to take hormone therapy and understands that there may be an increased risk of recurrence, I'm going to suggest something like tibolone over perhaps any of the other hormone therapies that we have in that case.
What about if your ovaries are removed? What happens there and what's the risk? How do we take that into account?
So, if your ovaries are removed, let's say it's for ovarian cancer prevention, then if you don't have a contraindication to taking hormone therapy, so you might still have your breasts and have a BRCA gene, but you're in surgical menopause, it's recommended and very important to take hormone therapy again to prevent those diseases of aging that happen prematurely when your ovaries are removed. Where the data is lacking is things like testosterone replacement in those women, because testosterone is made, as I said, by adrenal glands and by ovaries. And when you take the ovaries out, you're removing a big proportion of testosterone production that is still produced in postmenopausal women who have their ovaries in place. So it could be true that in women who have surgical removal of their ovaries, there's actually an even more role for using testosterone replacement. But certainly estrogens, progestogens, if there's a uterus present, would be recommended in women with their ovaries removed until the average age of menopause. At that point, you would reassess and say, is there still a reason for you to be taking this? Do you have symptoms of menopause or is simple better and we take you off your hormones then?
Interesting. But I my understanding is taking these hormones long term, is really important. So why is it that once they reach menopause age, it would be reassessed?
So not all women go on hormone therapy, right? So normal menopausal women who go through menopause and don't have significant symptoms are not recommended by any body to take hormone therapy preventively. We're not there. We don't know that the risk and the benefit equal out to recommend hormone therapy for prevention of cardiac disease or osteoporosis in postmenopausal women without symptoms. In the States, the FDA approves hormone therapy for two reasons. One is the treatment of vasomotor symptoms, and the other is the prevention of postmenopausal bone loss. So, all women technically are at risk for postmenopausal bone loss, but not all of them will develop osteoporosis or have the risks that would make them better candidates. So, it's a very personalized decision where do you have individual risk factors that make it safer to take hormones or less safe to take hormones on an ongoing basis?
Interesting. Now, my understanding is with vasomotor symptoms, you want to manage them full stop because of the cardiac risk. So that is one of those where it's a strong, like, let's figure that out, correct?
Yes, and that's why vasomotor symptoms across the board is the one indication for hormone therapy in most of places that have hormone therapy. So in Canada, it's the only indication for hormone therapy. In the States, it's one of the two, and so on and so
Okay.
forth. Vasomotor symptoms, not only for the cardiac benefit, but also for the quality of life impact, are recommended to be treated with hormone therapy in the absence of contraindications.
So now, for those who are, at high risk or just don't want to be on hormone therapy, I know that there's the NK3 antagonists like Veoza. I know Sage Therapeutic just got FDA approval for their product. I think it's on NK3 and NK2. So that's coming out soon because it just got the FDA approval. So I know they're working on the launch at the moment. Is that something that is an alternative that you're recommending for patients who can't take estrogen, or are there others? Like, how should we look at this?
Yeah, so in Canada, I don't have access to those NK3, NK13 antagonists yet. We're hoping soon, but that's one of the reasons I'm very jealous of you guys down south because these drugs are really potent treaters of hot flashes and night sweats, and they are the only product, again in Canada, not quite true in the States, that are not hormonal and that are approved for the use of treating vasomotor symptoms. So traditionally, we've always used non-hormonal therapies that are off-label. They weren't approved for that use, but they have the pleasant side effect of treating vasomotor symptoms. Few years ago in the States, they remarketed and reapproved a long acting salt of an antidepressant called paroxetine to treat hot flashes and night sweats, again, because it's one of the side effects. So you have a treatment that's non hormonal called Brisdel, which is FDA approved. We don't have the same thing in Canada. And then in 2023, you guys got Veoza or fezolinetant. We still don't, but this is the only treatment that apart from the one that you said has just been approved, that is actually on label and works as well as estrogen for the management of vasomotor symptoms. So I consider that to be a huge game changer.
This is a great quote. It's not fair to tell your patients, I just don't know. You should seek out a NOMS, which now is Menopause Society expert colleague. It's a conversation you have to have. I love that. Do you remember saying that beautiful statement?
No, it sounds like me, but I don't remember saying it. But I agree with it, so that's good because I'm consistent. I mean, we've all seen patients where we really just didn't know what to do, but it's not enough to just lie or brush off or say, I don't know anything about hormones. At minimum, you have to do the homework and connect your patient with someone who can help them because minimizing their symptoms is just not adequate anymore. It's not the standard of care. And then you might stand to learn something too when you read that consult letter
Yeah.
back or to do your own continuing education because we have a crew of aging women who are going through perimenopause and menopause and who are not their mothers. They do not want to take, I don't know, I don't care for an answer. They will demand better of you.
Yes. Um, I love that. And by the way, so the notes are 2 pages long, and that statement was about halfway through your talk, and as soon as you said that, I wrote, "Dr. Michelle Jacobson, interview her." It was like right when you said that, I was like, "She's someone I need on the podcast." Another thing that I love that you said is, for contraindications, because we've talked a lot about this, is you can choose to be ruled by them or ignore them.
Right. So that takes us back to that conversation on risk tolerance. So I don't sit in the car with my patients and make sure that they've put their seatbelt on. I don't pull the cigarette out of their mouth as they walk down the street. And I don't consider myself to be the keeper of the prescriptions. I think that women have a right to make bad choices, choices that I don't necessarily agree with, as long as they have the information. So it's on me or on my colleagues to provide the information about risk and benefit and reasons to use something and not. But then it's up to the patient to decide if her quality of life or her fears around osteoporosis or whatnot are worth taking hormone therapy. And if she chooses to take it, even if she has a listed contraindication, then I prescribe it for her because I think that people have a right to make their own choices.
I love that. Another thing you mentioned is loving the Mirena IUD. Talk to us about that.
Yeah, so that levonorgestrel IUD, IUS, it's used primarily as a contraceptive, although it also has the approval for heavy menstrual bleeding, and in the States, as the progestin component of a combination hormone therapy. So for women who have bleeding on HRT, for women who aren't good at remembering to take things, have side effects from other progestins, still have a need for contraception, etc., using a levonorgestrel intrauterine system is a great way of giving half of the combination therapy. And it is so potent in the uterus when it comes to dosing that you could give any amount of estrogen that's indicated on top of it and not have to worry about changing the dose of progestin to match the estrogen. So it's a great tool to use.
So, have you found that people with like the Mirena IUD, or if they're on birth control, because some have even said just take birth control instead of the typical hormone therapy, which I find fascinating, that if they're seeing the symptoms in the vulva or the vagina, to consider the vaginal estrogen. So, talk to me about that.
Okay, it's a bit more complicated than that. So, taking oral contraceptives increases sex hormone binding globulin. That's that oral estrogen causes the liver to produce more sex hormone binding globulin, and that's going to mop up a lot of your free testosterone. The vaginal introitus, so the opening to the vagina, is incredibly sensitive to testosterone. So, for young women who have nothing to do with menopause for many years, who are taking combination oral contraceptives, some of them will note a dryness or an atrophy in the vaginal introitus that needs to be treated not only with estrogen, but actually with androgen, with testosterone. And oftentimes, we also need to take our patients off of their birth control pills in order to get a resolution in their symptoms. In women who take birth control pills, let's say into their 40s, many of them will end up getting vasomotor symptoms even while they're taking this high dose synthetic estrogen. And that's probably because the way the ethinyl estradiol works in the brain is just different than the way estradiol works in the brain. And so you might find that a woman in her 40s getting symptoms on birth control actually needs to switch perhaps to something like an IUS and an estrogen, or switch birth controls to an S-tetrol containing birth control, because that might treat her vasomotor symptoms that developed while she was on birth control, but as her own native estrogen levels were decreasing. You don't want to keep people on combination oral contraceptives into their 50s and beyond because the synthetic estrogen puts them at increased risk of blood clots in the legs or the lungs, and their risk of a blood clot goes up as they age. So, usually in the late 40s, if the symptoms are otherwise well controlled, or the early 50s, is a good opportunity to make the change into more of the hormone therapies. And a nice way of transitioning if they need contraception is by using that IUS. The progestin containing IUDs are considered systems and not devices. So they're intrauterine systems. That's going to be your levonorgestrel
Oh,
containing ones, whereas your copper is an IUD.
got it. I had never heard of it described that way, so thank you. But the vaginal estrogen, if they are having symptoms in the vulva or vagina, that is something that can be used to help, correct?
It's almost a no-brainer. So anyone who's got menopause-associated dryness, irritation, pain with sex, bleeding, bladder issues that develop in the 40s and beyond can absolutely use vaginal estrogen, irrespective of what hormonal therapy they're using. And for the most part, irrespective of their medical history. So, breast cancer on aromatase inhibitor tends to be the most controversial area, but even then, there's actually very large studies, 50,000 women containing studies that look at the use of vaginal estrogen after breast cancer while on aromatase inhibitors and don't suggest any increased risk of recurrence.
What about the pill versus the cream? So I will say this, I started with the pill first and I noticed still pain with sex. And so I switched to the cream and helped immensely. And then I'd ask someone, "Do you need the pill and the cream?" And I had heard if you're fine, if the vaginal cream is working, then it's fine because the pill goes all the way up to near where your cervix is, and the cream is more on the outside and just at the entryway. So, given all those dynamics, can you talk to us about pill versus cream?
It totally depends on how you use the cream. So, when it comes to vaginal estrogen and vaginal hormone products for the treatment of GSM, the options you have are a couple of creams. One's conjugated estrogen, one's estrone. You have vaginal inserts. One is a tablet that gets inserted high to the top of the vagina with an applicator. Another is a soft gel insert that you insert with your finger. You've got vaginal ovules that contain DHEA, and those get used daily and they get turned into estrogen and testosterone in the cell. And then you've got your oral pill that treats vaginal dryness. Technically, these are all equivalent in terms of the line of therapy and the efficacy. So, what I find to be most important is what are you going to use? What is affordable to you, gets covered by your insurance? What are you going to be compliant with? Some women like one over the other. If someone's extremely dry, sometimes inserting that applicator with the tablet is hard for them. So, in that case, they might want to use a couple weeks of cream to help prime the tissue before switching to whichever one they find more efficacious. But in terms of dose, those vaginal tablet inserts are overall lower dose than some of the other creams, depending on the amount
Ah.
used.
Very helpful. Yeah, again, I don't want to put words in your mouth, but what I wrote down is she does not ask pathologists and hematologists about vaginal estrogen and simply speaks to the patient and makes it an informed consent discussion.
Exactly. So again, I don't think that there is risk to this, but I know that if we ask permission to use products like this, products that are meant to help with female genital health and sexual well-being, there will be a host of opinions that are not necessarily evidence-based. They are umbrella opinions that really stem from thinking women's vaginal, sexual, genital health is not important. It really undermines the importance for many women and the impact on their daily functioning. So I consider it to be my own privilege point as an expert to say this is safe or this isn't. There is a movement in the States to change this that I believe has recently been successful. But the insert, the product monograph that comes in a vaginal estrogen package, is the same as the one that comes in the oral estrogen package, despite the fact that it is 1/1000th the dose and that it is used for completely different reasons. So it's scary if you're using it for your vagina with a history of breast cancer to read that it's going to cause breast cancer if you take it orally. And it's simply not the same product.
Okay. Yeah. I haven't seen the result of it, but I do believe it was successful because I saw them posting that they went up to Capitol Hill. Real quick, one more quick question about birth control is because of the synthetic estrogen in it. Is there breast cancer concerns there? Is that a dumb question?
It's not a dumb question. There is so much evidence out there, some of which suggests an increased risk of breast cancer, some of which does not. The overall conclusion, when all of those studies are taken into a meta analysis and they take all of the results from all the studies that are done, is that it seems fairly breast neutral. We don't
Okay.
consider a birth control pill to be an increased risk of breast cancer.
Okay. So you mentioned how you really work with hereditary breast and ovarian cancer like BRCA, menopause after breast cancer, colon cancer, gynecologic cancer, and stem cell transplant. So it seems like the hereditary breast cancer is the one that is the greatest risk for hormone therapy and the others not so much, or are there things we should you should mention for those who may be dealing with those cancers?
So there's a nice article in The Lancet that was published. Martha Hickey is one of the authors that kind of takes you through all different cancers that can affect women and gives sort of a brief summary on
Okay.
whether hormone therapy is safe or not. Every cancer is impacted differently and has a different recommendation. And it is so complicated that even within uterine cancers or ovarian cancers, there are specific recommendations for specific types of cancers. So if you are suffering with menopause, if you are young, if you are average age menopause but still suffering with symptoms and you've had any of these considered hormone sensitive cancers, it's definitely worth seeking out an expert who has some access to this data and some comfort in prescribing. I to go through it all, it would take forever. Colon cancer
Okay.
seems to be helped by hormone therapy. Lymphomas, leukemia, stem cell transplant, we're wanting to use them because almost everyone who gets a transplant will have premature menopause, but there are nuances. What if she's had a blood clot, right? So what if she's got
Okay.
liver dysfunction from graft versus host disease? So it's really complicated.
Wow. Okay, I guess last question, and I don't know if this is a dual question or not, but I'll just ask it all at once and you can let me know the best way to answer it. So, on the one hand, after doing, interviewing over 150 healthcare experts now, I can't believe I can say that. It's so cool. And I really picked good ones. So, I'm really appreciative of this. Is a lot of it is finding the right doctor. And it's like, well, which doctor do you go to? Because there's so many subspecialties within these fields, right? But then it's also how, as a patient, can you own helping make that a good appointment? Because I think a lot of people will come in and just assume the doctor magically understands their background, and the doctor can only do with what they have. And so if we as women don't know what to say or the questions to ask, because clinicians are human, there could be a miss, right? So it's kind of
100%.
this, how do women show up? And then what kind of doctor should they be looking for?
It's so hard, and you're so right. Like, you as the patient are your best advocate, but that's really, really hard, especially if you have a physician who doesn't care, doesn't get it, doesn't feel comfortable, is scared of it. I would say that your best couple of bets are, first of all, following podcasts like these where you feel like you're getting evidence-based, reliable information. Going to things like the Menopause Society or the International Menopause Society's pages and reading their resources that are made for patients will help arm you with high quality information. And then, sort of last but not least, whether you're getting the answers you want or not, feeling out or finding a menopause specialist, and you can search the Menopause Society's database for a menopause practitioner close to you, is going to be your best chance at getting someone who follows evidence based care. But even then, you have to be careful because the 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 motivation for getting a MSCP, a certified practitioner certificate, may not be the best possible motivation in people who are still just trying to sell you something or push their own agenda. So listen to your intuition and be armed with your own good evidence-based research. A good book would be something like the Menopause Manifesto. Um, Resources like your podcast, Georgie, things like this are going to be your best bet.
And, I want to leave with this data point that I think everyone just really has to know. And it's not a fear tactic. It's more like just your gut is saying something. Just remember this. We are 50% of the population globally. All of us are going to enter menopause, full stop. And if we're entering, if, most of us, the average age is 52, we're high income earners. From a business perspective, this is literally the hottest population to target from a business perspective ever. Well, I really appreciate that you said yes. I was blown away by your discussion. And I had thought about doing a case study, but I feel like you gave, without a specific case study, like a lay of the land of kind of considerations. And I hope people don't feel overwhelmed by it, but more just like just the dynamics of how all this stuff works. And it might prompt questions people should ask their clinician. And I think we ended with how do you kind of navigate finding the right person. So I do think this is really going to help a lot of people and maybe even some clinicians who are trying to help their patients.
Thanks, Georgie. It's been great. Thank you.
And that wraps up another insightful session here on the Perimenopause and Menopause channel of the Fempower Health podcast. Before you go, I've got two quick, exciting invitations for you. First, join our vibrant community by subscribing to our newsletter. And it's not just any newsletter, it's your frontline update on groundbreaking women's health research, the latest health enhancing products, and unique discoveries you won't want to miss. All of this delivered straight to your inbox, cutting through the noise of social media algorithms. Better yet, you can pick the Perimenopause and Menopause edition or the Chronic Pelvic Pain edition or both. Second, if you enjoy our perimenopause and menopause content, don't forget that we also have a main Fempower Health podcast feed that covers a wider range of women's health topics. Additionally, if you're interested in chronic pelvic pain, you can subscribe to that specific feed too. Find these channels on our website or wherever you listen to podcasts. And if you love today's insights, show your support by rating and reviewing our podcast. Your feedback is more than just a pat on our backs. It lights the way for others seeking guidance and community in their health journey, amplifying the voices that need to be heard. And for a deep dive into today's topics, check out the show notes and explore our website at fempower-health.com. Our site is a treasure trove of knowledge neatly categorized by topics of interest, ensuring you find exactly what you need to empower your health journey. And your voice matters to us deeply. Whether you have a question, a story to share, or feedback on our episodes, reach out directly at info@fempower-health.com. Drop us a message on social media or hit reply on any newsletter. Your insights inspire our conversations. And don't forget to follow us on social media for more updates, tips, and community interactions. We're on Facebook, Instagram, and TikTok at fempowerhealth.perry.meno. Quick note, the knowledge we share here is to embolden you in discussions with your healthcare provider. It's not medical advice. Always consult with your doctor for health decisions. And remember, the diverse perspectives of our guests reflect their individual journeys, and it's not an endorsement by Fempower Health. And here's to empowering your health journey, one episode at a time. See you on the next perimenopause and menopause episode of the Fempower Health podcast.